Good morning, uh, partners and colleagues. I think we are live now, so we are ready to start. Good morning. My name is Stéphane Algan. I am from the European Commission, DG ECHO. I am the team leader of a team that is in charge of the operational development of the European Civil Protection Pool. And today I am your host for this discussion on health emergency response under the European Humanitarian Response Capacity. And more specifically, myself, the panelists, and with your contributions through questions on Slido, we'll try to answer the following question, or at least to harvest ideas that could help us answer the following question. What are the activities and options related to health emergency response which the European Humanitarian Response Capacity could support? It's a 1 hour session. And as I was saying, um, participants in the audience can not only can, but are strongly invited to submit questions to myself and to the panelists via Slido. You can do it anytime. I am assisted today by my colleague Alexandre Joly, who will collect and forward us these questions, and we will answer them as they come. So a strong encouragement to contribute through Slido. The starting point, as sort of scene setter, is the humanitarian aid communication of March 2021. So that was 1 year ago, which contains a commitment to develop a European humanitarian response capacity. And this communication reads that while the EU's humanitarian aid will continue to be delivered by the EU's humanitarian partners, there may be situations in which there is a clear added value for the EU to intervene directly. Actually, the objective for the EHRC, to use the acronym, is for the EU to support the member states and our humanitarian partners in the rapid delivery of humanitarian aid. So clearly, the EHRC should be seen as an enabler of the delivery of humanitarian aid. And more specifically, what we are aiming at is to enable more rapid, more targeted, and more direct EU interventions that can be triggered and steered by the Commission, by DG ECHO. But it is also about demonstrating a strong EU leadership and also to foster a Team Europe approach, which is to say a more joined up and more coordinated action between the Commission and the member states. And to achieve this, and particularly to be quick in the delivery, we need to have predefined and agreed arrangements with partners or service providers. The EHRC will have also to comply with a certain number of principles. First of all, it should have a gap filling role. It is not at all our intention, and we should avoid it by all means, to duplicate what already exists and already works well. So gap filling role. It's not easy because if you take the humanitarian aid provided by the EU, we have already a number of partnerships in place, a number of tools, so it's already a crowded place. Just to speak of the EU. Plus, we should try to have the good complementarity with the Union Civil Protection Mechanism. This UCPM, it's true, was designed mainly for intra-EU solidarity to respond to disasters, but actually this UCPM has been mostly used outside the EU and often in parallel with the delivery of humanitarian aid. So good complementarity with the UCPM is absolutely key. Of course, Second principle for the EHRC, full compliance with humanitarian principles. Third principle, we want to build on existing coordination systems. We are not going to create or new coordination systems. And in particular, we want to build on what already exists within the UN or with the UN and internally in the Commission to build on the existence of the Emergency Response Coordination Center, ERCC, that will have to play a key role to coordinate the implementation of the EHRC elements. The EHRC is also 100% under the humanitarian aid regulation and budget. So we are not changing the rules of the game. We are not creating new rules. We work strictly under the rules that currently exist. And the EHRC is also mostly centered on the logistics and supply chain, and it will be an opportunity there to implement the newly adopted DG ECO logistics policy that was also presented during the humanitarian forum. But not exclusively, and clearly the medical strand that we are discussing this morning is not about logistics and supply chain. So what we have been doing since March last year, we've had a lot of internal and external consultations and brainstorming sessions to identify and shape the various parts of the EHRC. Currently, the situation is that we are ready to launch a first batch of EHRC tools, which are pre-positioned stockpiles of emergency kits and also a reinforced humanitarian air bridge. So this is ready to be started. And then in parallel, we are also working on a second batch of EHRC tools for which we need more thinking, more consultations, and these are setting up rapid response teams. And for this, we will be mainly drawing on internal human resources, um, having arrangements in place to deploy an EU compound, also the provision of common services such as on warehousing and last mile delivery. And last but not least, a last component about medical capacities. And on this last element, medical capacities, coming back to the humanitarian communication, it says that the EHRC, could also further enhance the EU's medical response capacity for future health emergencies, building on the existing EU Medical Corps. So EU Medical Corps, that's all medical capacities, assets, expertise, which are available under the Union Civil Protection Mechanism, in cooperation, where relevant, with the future EU Health Task Force to be established under the coordination of the European Center for Disease Prevention and Control, ECDC, and that's why we have today Vicky Lefebvre with us. And to do what? To assist local response to outbreaks of communicable diseases in synergy with the Union Civil Protection Mechanism. Here again, we have this important point of effective complementarity with the UCPM, and also to strengthen the preparedness in member states and in third countries. So for what concerns the medical component of the EHRC, the options that are currently being discussed, and we'll discuss them this morning. One is about expertise. It would be about facilitating the deployment of EU public health experts or public health teams, which could include epidemiologists. Um, but it could also be rapid response health coordinators or information management experts. So this is about expertise. There are also other options that we are thinking of. One is supporting the establishment of an EU emergency medical team, EMT, and I'm glad today to have with us Flavio, who will tell us more about the WHO EMT initiative. Another option could be to establish a stockpile of medical items. And last but not least, another option could be also setting up a medical evacuation capacity. So, and there could be more, and this is what we would like to discuss with you today. So, man, now going to our panelists, as I was saying, a first principle for the EHRC is that it should have a gap filling role. And to have this role, it's important that we identify needs and gaps. So actually, that would be my first question to three of the panelists, to Ian, Flavio, and Wojtek. And I will ask each of them from their own perspective what they see as needs and gaps. And on this, I will first ask Jan to speak. So Jan is our health expert working for DG ECHO at the DG ECHO office in Kinshasa, DRC. Jan, you've been working for more than 10 years with for DG ECHO, and previously for a number of years for medical NGOs in the same field. You are a physician by education, so you are certainly qualified to share with us your views today. So yes, indeed, Jan, I mean, building on your personal experience, where is it that you see a need for the Commission to increase its ambitions in health emergencies beyond the current UCPM actions outside the EU and beyond the existing EU humanitarian aid toolbox? Jan, over to you from Kinshasa.
Thank you, Stefan, and thank you for inviting me for this talk. I hope the connection is okay. It's challenging from Kinshasa here. You can hear me. So yeah, I work for ECHO here in Kinshasa, and so humanitarian aid. Looking at what health emergencies entail for DG ECHO. So first of all, you have the most of the humanitarian needs arising from conflicts have health emergency components. There is the direct physical violence that needs to be responded to, but also, more importantly, indirect impact on health of conflict situations. In these contexts, disease outbreaks, and I will mainly talk about disease outbreaks because that's where I have been working on intensively over the past years. In these conflict situations, disease outbreaks are more frequent or more challenging and need humanitarian response. Besides that, you have health emergencies like disease outbreaks, natural disasters, accidents, which can have humanitarian consequences and then also need humanitarian response. So just to give a small idea of what outbreaks, disease outbreaks entail for DG ECHO for the period 2017-2021, we have like over 200 actions that were dealing with disease outbreaks. Most of a big chunk of it was COVID related, also Ebola and cholera, and then a few other yellow fever, Rift Valley fever, and so on. But so looking at my experience from the field, I was in 2014 in Guinea for the West Ebola outbreak, and I think this outbreak was somewhat a game changer for many of us. Also for ECHO, it opened some doors towards engagement beyond classical humanitarian donor role. So I think that one of the first remarks I had when arriving there was that I was sent alone, and then other donors that they deployed rapid response team with disease detectives, with outbreak response, outbreak support staff, assisting in the designing of outbreak strategies and interventions, and I was like really envying somewhat this huge capacity that was deployed by some of the donors. Traveling to the epicenter of the outbreak, then in Gekedu, one of the first, I saw one of the first EU, what I call EU elements of response capacity, the famous EU mobile lab of Professor Günther. Later on, a Belgian lab joined as well, but so it was really for me the first time I saw, like, wow, there are EU response capacities that can be joined to the ECHO response and overall outbreak response. To end of 2014, Commissioner Stylianides and Andrea Kaitis went to Conakry, and so they had a meeting with CDC director of then, Tom Friedman, who encouraged them, who asked them to beef up French-speaking epidemiological capacities, which was done over the next months and years. And I think this was one of the first and biggest ECDC deployments with over 600 experts that went to the West Africa, the Guinea outbreak. I think that another EU experience that I witnessed there was the deployment of the EPRUS, the Établissement de Préparation et de Réponse aux Urgences Sanitaires, French government institute that deployed experts, disease control experts, clinicians, to work together with Red Cross, French Red Cross, in a treatment center. So I think that those were some of the ideas on what can EU do more better in disease outbreaks. Later on, I went from the 9th to the 13th Ebola outbreaks here in DRC, and wow, the 9th outbreak, it was really the first time WHO deployed its WHE, fully operational and engaged teams. Impressive, I have to say. I was kind of embedded with them in Macenta. So it's another major milestone, I think, in disease outbreaks. For ECHO, we did play our more classic role of donor there. We didn't engage ECDC experts, though in the 10th outbreak, which was the main outbreak here in DRC, again, the ECDC experts were deployed, and I think that was really of added value for the overall response, but especially maybe for ECHO as a donor to improve our strategy, to improve our operations, and so on. Another experience on response capacities during the 10th outbreak was the deployment of a Norwegian medical team that introduced a new medevac capacity. So yeah, I think that was that gives also ideas on what we can do more or different in kind of outbreak settings. During the COVID pandemic, so over the last 2 years here in DRC, been quite engaged in coordination, advisory mechanisms at national level, funding of, so we have funded different partners for control interventions, but we have also very close collaboration with, first of all, with our Commission development services, with implementing partners from Belgium, from Germany, and GIZ, but also with research institutes from France, from Belgium, the Tropical Institute from Antwerp, for instance, which were, this collaboration was quite interesting also, I think, this linking up of different EU capacities, important to better steer the response and come with a more comprehensive approach. So yeah, during the COVID, we had also the first humanitarian air bridge with bringing in supplies and teams for the response. For the other emergencies, it's a little bit more difficult. The other health emergencies, you have the migrants crisis, you have accidents like in Sierra Leone, the burns, and in Lebanon. Teams were sent, but yeah, I have less experience on that. So I think where can, from my point of view, where EU can increase its ambitions and capacities is to build up EU capacities and linking up different capacities that are currently built up inside EU, for instance, the HERA and also the different role, the extended role for ECDC, but further extending also towards support, and it's a mutual support. I think it's It's not a one-way support to countries that have less response capacities, but we have also to see it as an opportunity to be prepared, to gain experience, to learn from how disease outbreaks that we currently don't have in EU, like Ebola or malaria and so on, but to learn from that. With the climate crisis and so on, we will have more and more risks to disease outbreaks, and we have to be better prepared. So there is really an interest from both sides. I think rapid response teams need to be created that are field-based, that can be of value inside and outside the EU, with teams of technical experts joining the response. So I think that's a little bit what I can say from my field experience, direct field experience here in DRC, Guinea, and other places, mostly in Africa. Over.
Thank you, Ian, for sharing with us your field experience and your insights on this. Now I will basically ask the same question to Wojtek Wilk. So just to introduce you first, Wojtek. So you are the president and CEO of PCPM, which is the Polish Center for International Aid. It is a non-governmental organization. PCPM owns, if I can say so, an emergency medical team. You are the team leader of this EMT, which is one of the 30 plus classified, EMTs classified by WHO. And it is also one of the EMTs committed, offered by member states, and in the present case, this is Poland, to the European Civil Protection Pool for development inside or outside the EU under the Union Civil Protection mechanism. And I have to say that your EMT has been deployed already quite a number of times inside the EU and outside the EU, and most recently to Madagascar. And prior to joining PCPM, you worked for more than 10 years for UN OCHA in various parts of the world. So that was just to introduce you, Wojtek. So over to you, again, from your experience, where do you see operational gaps that the EHRC could fill in?
Well, Stefan, thank you very much for having me on the panel. It's a great honor. To give you a concrete example, our latest mission, which just ended on the 6th of March, was an EMT deployment to Madagascar. And once we started the deployment procedure, we quickly realized there are no flights to Madagascar other than one flight from Paris, which is completely booked solid for the next month. And there is literally no way to get to the island. We had to charter an aircraft. While chartering the aircraft, we had to make really painful decisions how many staff should travel versus how many supplies we should take, because the aircraft capacity was very limited. We literally had to fly on a small aircraft from Nairobi to Madagascar with just the core team of the EMT plus some supplies. So this kind of reinforces my very keen interest in the two areas that the European Humanitarian Response Capacity is bringing, which is the humanitarian air bridge, because this was badly needed in Madagascar. We are having more and more emergencies where, due to the different reasons, the getting to the country is getting very, very difficult, which then obviously constrains the whole rapid response capacity. I'm thinking not only of Madagascar, but even if we look back at the Nepal earthquake in 2015, getting to Nepal was very difficult because there was a cracked runway and there was limitations how many aircraft could arrive in Nepal. But also some of the more remote places, like the islands in the oceans, are also have very limited connectivity. And here a humanitarian air bridge that flies on a certain schedule and the teams can plan their deployment or rotations based on the humanitarian air bridge, this would be a massive help to the international community at large, but especially to the responders. Also, the other area is the prepositioning. For instance, in Madagascar, we had to make a painful decision how many IV fluids we should take with us. And we ended up taking 500 kilograms of IV fluids, which equals 5 passengers on the aircraft, right? While if such items could be prepositioned either with European Union delegations or with some sort of regional hubs, this would really save a lot of those really painful decisions that have to be taken when an emergency happens in hard to reach place. So for instance, for PCPM, as one of the largest Polish international NGOs, like one of the lessons learned after the recent deployment to Madagascar is to set up a regional warehouse in Nairobi so that we could also have the proper stockpile of items for emergency medical team deployments in Africa. And we tend to cooperate on this quite a lot with the WHO. But I think that also prepositioning of supplies for other responders with the EU delegations or EU offices in the most affected countries, I think this is a really good idea. And if this had been the case in Madagascar, it would have really changed our logistics, would have really positively affected the way we have responded to this emergency. Also, on the rapid response teams, I wanted to highlight that when the EMTs deploy, we not only us but also other EMTs, we have developed a kind of a good practice that the EMTs should deploy first a small assessment team to check what are the conditions, check what are the needs on the ground, but also talk to the Ministry of Health of the receiving country and kind of really manage their expectations, because very often the Ministries of Health expect, I don't know what kind of super hospital, field hospital to be deployed, and this ends up a group of 15 people with a bunch of tents, right? So either if those people doing the first groundwork for the arriving teams, maybe they should be added to the rapid response teams that you are talking about, or if not, then at least if they could be put as the first people to fly on the humanitarian air bridge, this would be extremely useful. I mean, this to some extent happened in Madagascar, but there were only 2 flights into the island, which was not enough for everybody to fit on the aircraft. So again, I think this is a pretty strong case study. Medevac, I think medevac will be needed not only during the natural disasters, but look, there are more and more responders going into Ukraine. How can we facilitate that work, right? I mean, the whole insurance coverage, the whole medevac is a major challenge in Ukraine. But also at least for the Polish NGO, I think that working inside Ukraine, delivering medical assistance under EU flag would be not only an honor for us, a privilege, but also an additional protection. I have seen, unfortunately, Russian forces bombing hospitals in Syria as I worked in Syria. I've seen it firsthand. And it's really a high concern that at one stage, medical facilities, I mean, they have been already bombed in Ukraine, about 50 medical facilities, but potentially even the international providers could be affected. So the more such providers can work under the EU flag, I think it is the better. Thank you.
Thanks a lot, Wojtek, for these, I would say, very concrete ideas based on a very recent experience you had as an EMT in Madagascar and the difficulties also in relation to the Ukrainian crisis. So thanks a lot for these very concrete ideas. Talking about EMTs, so we have today Flavio Salio with us. So I could say that, Flavio, you are the big boss of the EMT initiative at the World Health Organization. So actually, you are the network leader. This is your official title for the EMT network at WHO, and since for the past 15 years or more, you've been working on health programs, emergency response coordination in different types of emergency. You were head of mission in several countries, so you have certainly a wide experience of dealing with emergencies, and particularly health emergencies, of the consequences on health of some emergencies. So my question again to you, Flavio, from your perspective, sitting in WHO, where would you see needs and gaps for the EHRC to step in?
Thank you, thank you, Stefan. Thanks for the invitation, and good morning to everyone. I would say probably we should start with what was mentioned in terms of humanitarian response. I think what we have moved in terms of the EMT initiative, we're looking to basically to the increasing threats that we have seen globally. So we talk about the increasing threat in terms of climate change, the infectious disease outbreak that was mentioned before, as well as the conflict. So the direction that definitely the initiative has taken is going to identify standards for medical team that responding to the three crises, the situation of disaster, highly infectious disease, and conflict. Recognizing clearly that, first of all, requirements are different, as we say, scope and scale as well of the responses are different as well. I think when we look into how the system can contribute, definitely I would say that what the COVID shows in terms of the response is that probably moving from a standard typology of EMT to more a modular, what we call modular approach. So try to address as well some of the gaps that are clear. So colleagues before mentioned about the response to Bata explosion or Sierra Leone, which definitely highlighted the need for specialized care teams on burn. And I think that's just one element that, for example, the EU teams can massively contribute. We have seen the medical evacuation. So we do have launched as well a technical working group within the initiative looking specifically to the medical evacuation, recognizing that fact that we have conducted them since long time, but then during the COVID itself, during today, the response to Ukraine, we still see that we are discussing about criteria, we are discussing about what standards should be considered and how those evacuations should be performed. I think that is definitely another element that we step into. The full component of helping, I think the scope as well and the of the team deploying need to be clearly defined. I'm talking about today we have always looked to a surge, as you described at the beginning. So there is obviously a spike and increase on needs. And then obviously we are taking the opportunity to have teams responding and supporting the system to cope with this kind of needs. And obviously, I think Ian presented a situation as well. Those needs might be protracted for long. And I think that need to be clarified as well on where and how those teams will be able to support. The last part I would say that's what is missing. At least we have massively starting to invest more in supporting the local teams, where basically there is a strong support in terms of getting them ready and prepared based on our current capacity they have in country, strengthening the system. So some work in when it comes to the readiness of a country. I do believe that those teams can contribute, because then it will be much easier for them to deploy in support of those, and maybe in a configuration that is more adapted to the content itself. So I think this is all the work that is it's ongoing, and I think that does require more and more standardizations. The last part, I think there has been a clear discussion around how the EMT, the medical team, can link with other health capacities. I think the discussion around the rapid response team. I think we use a lot the rapid response team as definitions, then need to be clearly clarified on what we refer, what is the scope of that. But I agree actually with Wojtek, maybe the idea of having a rapid response team with a clear objective of supporting and look into gaps that can be then communicate further to the system in way to tailor the response itself. And obviously, he was referring to the forward team, which has been putting forward more, setting and preparing the ground for my team in way to make sure that obviously I will have everything ready as soon as I hit the ground to be able to provide the services to the affected populations. Thanks, and back to you.
Okay, thanks a lot, Flavio. Also again for sharing with us some very concrete ideas, and I understand that on some of them WHO is already working on or investing a lot. So I really took note of everything that you've explained. So before we move to Vicky, I'm looking at my colleague Alexandre, who is telling me that we haven't received any question yet on Slido. So again, do not hesitate to put question to the panelists. Don't wait for the end of the session to do it. You can do it anytime. So really use Slido. This is what this event is about after all. So now we will move to the second part of our session, which is more about discussing the EHRC options for the medical strands. And one of these options is to have arrangements in place for the deployment of public health experts or teams. And on this, I'm glad to have with us today Vicky Lefebvre, who currently work in Stockholm for the European Center for Disease Prevention and Control. So this is, in short, the EU agency that is in charge of strengthening the EU defenses against infectious diseases. At ECDC, Vicky, you head the public health functions unit, and you've been working in this capacity since 2020. Previously, you were Director General in the Belgian Food Safety Agency. And you also worked for some years for the European Commission, DG Research and Innovation, as a research program officer responsible for the management of EU-funded research projects in the area of public health and food safety. But if we have you today, of course, it's in your current capacity at ECDC. ECDC, there is currently a revised legal basis, which is, we hope, will be adopted very soon. This new ECDC legal basis or regulation includes a provision for setting up what is called a European Health Task Force, EHTF. So that would be my first question to you, Vicky. What is this European Health Task Force all about? Its composition, mandate, mission, maybe the timeline for making it operational. Over to you, Vicky.
Thank you very much for the nice introduction, and thank you for inviting me. Yes, well, the EU Health Task Force, as you say, is currently a concept embedded in the ECDC mandate and the cross-border threat to health regulation, both not adopted yet. So at this stage, it doesn't exist. We hope to get the legal text approved by June, but this depends on the trilogues between the Commission, the Parliament, and the Council. But in the meantime, of course, we are preparing for this implementation, and the Public Health Functions Unit is in charge of setting this up and coordinating this, because this is the task we have in the new mandate. So this would actually be a European public health workforce to rapidly respond to public health emergencies and outbreaks of infectious diseases. So the scope is infectious diseases and public health. So these are not medical teams, these are not doctors and nurses, but these would be epidemiologists, virologists, microbiologists, vaccinologists, mathematical modelers, biostatisticians, data managers, so different kinds of profiles with a different kind of task. And the fact that this task force is now being set up is, of course, as a direct result of the COVID pandemic, where we have seen a gap in the EU in this area. So this is about scaling up the EU intervention mechanism to rapidly respond to emergencies of infectious diseases, and not only in outbreak settings, but also strengthen preparedness, let's say, in peacetime. So as it looks now, the composition of this pool of experts would be ECDC experts. It would also include fellows in training under the APIET and UFEM fellowship programs, which are headed by ECDC. And of course, it would include member state experts to be appointed by member states' national authorities and included in the pool. And this will be the bigger part of the extended workforce. So the first thing for us to be done is to set up the mechanism to appoint the people that will be part of the pool and set up the steering board of this task force. So in terms of scope, I said this is infectious diseases, so it's response and outbreak settings, allowing rapid deployments and mobilization of experts, but also remote support if needed. And then in non-crisis situations, the focus would be on strengthening preparedness in the EU, but also outside of the EU. In the mandate is also included that ECDC should set up indicators for EU and member state preparedness, and also a framework for EU preparedness and EU preparedness plans. What should they include? What should be the minimum? And then in addition, a system to assess if member states are actually prepared as agreed in the CBTH. In terms of preparedness, it would also include preparedness to respond rapidly in outbreak settings. If I give you an example for COVID, every time we have a new variant and a new wave, we have the same question: how transmissible, how severe? What about immunity? Do the vaccines work? Do the diagnostics work? What about vaccine effectiveness? And these questions are answered each time too late. And to be able to do that, of course, you can answer some of these questions pure in lab settings, but a part of these questions need to be answered by studies implemented in the field in crisis settings. So this is what we need to be better prepared for in the future with member states, and we can also extrapolate this to third countries. In terms of geographical scope, of course, this is EU-EEA, but it also includes non-EU countries such as pre-accession, European neighborhood policy, but other third countries. So depending on the geographical scope, the trigger mechanism will, of course, be different, because this task force will be mobilized upon request. And this mechanism needs to be implemented in a legal act. So this will be the next step for DG Santé to come up with an implementing act on how to trigger and activate this task force. So in this frame, we need to take into account existing mechanisms, of course, UCPM and the European Medical Corps. I mean, the health task force could become the public health pillar of this mechanism, which currently exist in the concept of the UCPM and the European Medical Corps, but while the EMT there are very strong, the public health pillar is not, and it's a bit the outsider. And this EU Health Task Force will give us the opportunity to actually strengthen also this pillar. And then, of course, we also need to take into account existing other mechanisms as WHO GORN and see how we can work with those mechanisms and also strengthen those mechanisms. So I think in terms of what it is or what it's going to be, this is where we are now.
Okay, no, thanks a lot, Vicky, for this clear summary and overview of what the European Health Task Force is about and where you currently stand before it can become operational. So I took note that you expect the CDC mandate and the cross-border threats regulation to be formally adopted in June. This is sort
what
of
we would
target date.
hope.
I know it's
The trilogues
you
are ongoing, and there is
okay.
an agreement
Yeah.
in the trilogues on the
Yeah.
ECDC mandate, but there is no agreement on the cross-border
Yeah.
threat to health regulation. So it
Yeah.
depends on
Yeah.
the tripartite there on when they will reach agreement, and also under the existing presidency. Let's hope this can be done under the existing presidency. If not, it will be handed over again. So this is the challenge now, because the two texts go hand in hand. One cannot be approved without the other.
Yeah. Okay, thank you. And you also said clearly that the health task force could be deployed both inside the EU but also possibly in non-EU countries. On this, of course, inside or outside the EU, it could be in cooperation or under the Union Civil Protection Mechanism. But when it comes to non-EU countries, uh, possibly these deployments could happen as humanitarian assistance. Um, would you have any thoughts about it? Do you see any particular challenge, and do you see a possibility that one way or another the EU, the European Health Task Force could become part of this EHRC?
Yes, certainly. I mean, listening to you on what these rapid response teams would be about, I see a clear opportunity there for the health task force to become the public health component of these rapid response teams, because in humanitarian crisis, natural disasters, I mean, it's important to have the public health component on the radar very early on. So in these assessment teams, I think there should be included standard, the public health expertise there as well. I mean, one example where we deployed ECDC experts with under the UCPM with DG ECHO was like the cyclone Ide in Mozambique in 2019. Where of course you have the immediate casualties and the need for the medical teams to step in, but very soon, I mean, with floodings, unhygienic circumstances, crowding of people, there were major outbreaks of cholera, also malaria, measles. So the public health component should be there early on. And this is a role we see certainly for the health task force under the EHRC rapid response teams. I mean, other examples were the Ebola outbreak in DRC that Jan already explained, where ECDC was then deployed with ECHO, and on the one hand, supporting WHO direct public health response in the field, and then on the other hand, also informing and liaising with ECHO as a donor to guide further response from their end. What we are doing now also with UCPM is related to the situation in Ukraine. We deployed 2 experts in Poland for this week and next week. So they are part of. I see Wojtek laughing. I mean, they are part of a UCPM assessment team. They liaise with the Ministry of Health. They have gone through reception centers. So this purely from a public health perspective, what support can be provided by ECDC in terms of, okay, what infectious diseases are to be taken account? What about polio? What about measles? What vaccination strategies? What surveillance systems to make surveillance in the reception centers? We see now that people move very quickly from those reception centers. After 3 days, they're already in the community and they're placed because there's quite big solidarity in the community. So it's very different from the situation a few years ago in Greece, where people were more stuck in these centers and where we had a completely different situation. So now this moves to, okay, how do we then set up surveillance in the community? How do we sensitize GPs? I mean, so this is what's going on now in this 2-week assessment missions, and we hope we can support the Polish national public health authorities, but we also want to learn and bring back messages and lessons that we can use in other countries, because the next in line for deployments could be Moldova. We're still discussing. This is then non-EU. So these are some examples of how these teams could support EHRC in humanitarian crisis.
Okay, thank you. Thanks a lot, Vicky. I see we have now less than 10 minutes left to have to discuss a bit the other options which are being discussed for the medical part of the EHRC. So that's EMTs, public health teams, we've discussed that, but also medical stockpile and MEVAC. I know that some of you have already mentioned some of these elements previously. But I would maybe on the question of EMTs, I mean, I would simply ask Flavio to tell us really what is the added value of the EMT concept, of these EMT standards that were developed and adopted. What is the added value from an operational perspective? And just to say that as a Commission, we have mostly deployed EMTs inside and outside the EU under the UCPM, so civil protection. What would you see, Flavio, as opportunities, but also maybe constraints to deploy EMTs in a humanitarian, purely in a humanitarian setting context? But first, maybe on the added value of EMT standards, if you could briefly tell us about it.
Yeah, thanks. Well, I think I will. We have looked to the standard and the classification system that was put in place even during the last 2 years of the COVID, and how much EMT have been engaged with that. What came very clear is that the system was set initially for being a given level of predictability and reliability that is extremely important in such kind of responses. But at the same time, actually starting to show much more flexibility. I think that was something that, compared with the previous negative connotation that we were seeing as being too rigid, not applicable in other health emergency, except probably sudden onset disaster or disaster. Sudden onset disaster, I think it was not true, in a sense that it was actually investment on key elements, as we always promote. The look into the system in the way I build my team, clearly understanding of the supply requirement, like even Wojtek was mentioned before, investing on my staffing, and then investing on the structure that can become. So the 4 S's that we're always promoting give the added value and the level of flexibility then to readjust based on the differences in context. I think that's definitely the added value.
Okay. And then my second question was, I mean, beyond what we are already doing under the UCPM, deployment of EMTs under UCPM, how would you see the deployment of EMTs through the EU as EU humanitarian assistance? I mean, do you have any particular thought on this?
Yeah, I do believe that there is a need of major investment in terms of awareness and making sure country understand the added value and what is exactly the mechanism, because then definitely can be a negative a barrier to deployment, and as was mentioned before as well, maybe not even understanding of what they are receiving and why they are receiving. I think that is definitely one. And the second one, I think, would be important as well to ensure that whatever proposal comes basically still align with a level of standardizations, because that could create confusions in the future. And as we know, improvisations is never good when it comes to emergency response. Flexibility, yes, but improvisations definitely not.
Thank you.
Thank
you, Flavio. So mindful of the time, it's less than 5 minutes left. Maybe to Wojtek, as an NGO, because PCPM is an NGO, would you have any particular thought or idea in terms of opportunities, maybe, but also constraints for NGOs to be part of this medical strand of the EHRC? Do you see any
Stefan, for the sake of time, let me focus on maybe just one or two most important things. Up to COVID, emergency teams used to deploy maybe once a year or even more seldom than that. With COVID, there has been a torrent of requests. I counted the requests issued by the EMT Secretariat for COVID-related deployments and other deployments 2020. There were 67 of them, right? Only for about 30 teams, and not all of them have deployed. So there was a need, and it continues to be a need for the emergency medical teams to deploy several times in a year, which for NGOs, then it's a considerable funding challenge, because we are talking about a few €100,000 every time you deploy. So indeed, if there could be some sort of an encouragement from the side of the Commission, reaching out to your EMT NGO partners saying, hey guys, listen, there is this deployment, and with a support and also financial backing of the Commission, would you be able to address it? I think this would be really interesting, because for instance, for Poland, during the summer, our COVID caseload is very low. This is the time where we can deploy, but sometimes some places are too far. Sometimes, for instance, I remember Flavio, the EMT Secretariat, putting up the request for Papua New Guinea. We were very well slotted to go there, but this was beyond our reach. So encouragement from the side of Commission, helping us shoulder the cost of deployment, and also some of the deployments take not 3 to 4 weeks, they take 2 to 3 months. This will be really, really encouraging. And I think at the end of the day, this would maximize the response capacity and maximize the response capacity that goes under the EU flag.
Thanks a lot, Wojtek. Message clearly received. As we are nearly approaching the end, the final word will be with you, Jan, for last thoughts, maybe reflecting on what Flavio, Vicky, and Wojtek have said. I would just like to thank our 4 panelists for being present today with us and for sharing their insights with us. That was most useful. I took note of everything that you said, and with my colleague Alexandre, we will digest it and make best use of it. But the final words with you, and you have, I think, 1 minute left, Jan.
Thank you very much, Stefan. What an honor. I think indeed what we aim for is to fill gaps in existing systems. But I think from a European side, we have also to look a little bit further and to increase our capacities in global health security. I think developing capacities inside EU, that's one thing, and we are going at the right way, I think. But we also need to look beyond, because especially for outbreaks, it's a global health issues that are concerned. So related to that, I think what is very important is to link the different capacities that exist already, to build up capacities that exist but need to be reinforced. Like Wojtek was saying, we have to invest in existing NGOs' capacities to improve their qualities, to make sure that next time they can respond with the same assets and so on. So linking strategic cooperation between different parts of the EU and the DGs and the member states and so on, but also with the external capacities, African CDC, WHO, and so on. So I think we come from far on global health security, but I think the COVID and the Ebola outbreaks gave us a stimulus to finally do some more at the EU, for EU, but also for the world as a whole. Thank you.
Thank you, Jan, and thank you, Vicky, Wojtek, and Flavio for being present today. We can, I think, close here and see you very soon. Bye-bye.
Thank you very much.
Thank you very much.